Bismillah ar-Rahman ar-Rahim. Pulmonary thromboembolic disease. Epidemiology and pathophysiology of pulmonary thromboembolic disease. The definition: pulmonary embolism is an obstruction of part of or the entire pulmonary vascular tree, usually caused by thrombus from a distant site. The epidemiology: the overall annual incidence is 60 to 70 per 100,000, with a United Kingdom annual death rate of 100 per million. The estimated overall population incidence of deep vein thrombosis (DVT) is 0.5 per 1,000 person years. Pulmonary embolism may account for up to 15% of all post-operative deaths. It is the commonest cause of death following elective surgery and the commonest cause of maternal death. Post-mortem studies have consistently shown a frequency of 7 to 9%, and large inpatient studies have shown a frequency of around 1% with a mortality of 0.2%. The mortality is much higher in patients with serious underlying comorbid disease. The incidence is likely to be stable, but improved diagnostic methods mean that it is probably reported more frequently. Pathophysiology of pulmonary embolism: 75% of thrombi are generated in the deep venous system of the lower limbs and the pelvis, probably initiated by platelet aggregation around venous valve sinuses. Activation of the clotting cascade leads to thrombus formation, with Virchow's triad, which is venous status, injury to the vessel wall, and increased blood coagulability. Predisposing to thrombus formation, venous stasis is increased by immobility and dehydration. In addition, coagulation factors may be altered in various disease states, as for example in the acute phase response, malignancy, and autoimmune disease. 20% of the leg thrombi embolized with a higher incidence in above than below the knee clots. Large clots may lodge at the bifurcation of the main pulmonary arteries, causing hemodynamic compromise. Small clots will travel more distally, infarcting the lungs and causing pleuritic pain. These are more commonly multiple and bilateral and are found most often in the lower lobes where blood flow is greatest. Thrombi can also develop in the right heart following myocardial infarction. Paradoxical emboli start within the venous system and enter the arterial circulation, usually via a potent foramen ovale, causing right to left shunt. They typically present with features of cerebral ischemia, and this should be considered as the cause for a stroke in the young. Septic emboli are found in and arthritis in association with intraventricular septal defects, arteriovenous shunts, or central venous access. Hemodynamic effects of pulmonary embolism. Effects depend on the size of the clot and which area of pulmonary vessels or pulmonary vascular tree it subsequently obstructs. as well as the pre-existing state of the myocardium. As the pulmonary vasculature in healthy lung had a large capacitance than the mean pulmonary arterial pressure, PAP, pulmonary artery pressure, does not rise until at least 50% of the vascular bed has been occluded. As the pulmonary artery pressure rises, right ventricular afterload increases with a resulting increase in the right ventricle end diastolic pressure, and the right ventricle will start to fail as the pulmonary artery pressure reaches over 40 millimeter mercury acutely. This causes a reduction in pulmonary blood flow, leading to reduced left ventricle filling and a reduction in systemic blood pressure. Adequate blood volume of the right side heart filling is vital. The secondary effects are much worse if the right side filling cannot be maintained, as for example, if the patient is dehydrated, hypovolemic, or in erect position. Arterial hypoxia results from several factors: reduced cardiac output, consequently, a low mixed venous PaO2, a higher perfusion to the remaining alveoli, resulting in inadequate oxygenation of this blood. Hypoxia will be worse if there is a larger premorbid ventilation perfusion spread, as for example in the elderly and in those with pre-existing lung disease. The increased blood flow with the lower mixed venous PaO2 passing through the low VQ areas overwhelms their oxygenating ability. It is therefore possible for a young person with healthy lungs to have a normal PaO2 and A gradient following a significant pulmonary embolism. Death is due to circulatory collapse from the inability of the right heart to acutely maintain an adequate cardiac output. The etiology. Risk factors can be divided into major and minor factors. This division is important for the assessment of clinical probability. The major risk factors, the relative risk multiplied by 50 to 20, includes surgery such as major abdominal or pelvic surgery, orthopedic surgery, especially lower limbs, post-operative intensive care, obstetrics such as pregnancy with higher incidence with multiple births, cesarean section, and preeclampsia, the malignancy such as pelvic or abdominal malignancy or metastatic or advanced conditions. Lower limb problems include fractures or varicose veins, reduced mobility, such as patients in hospital or institutional care or long haul flights. The last major risk is the previous proven venous thromboembolism VTE. The minor risk factors, in which relative risk multiplied by 2 to 4, include cardiovascular risks such as congenital heart disease, congestive cardiac failure, hypertension, central venous access, superficial venous thrombosis. Estrogens add a risk factor, such as patients taking oral contraceptive pills, especially third generation higher estrogen containing, and hormone replacement therapy HRT. Miscellaneous minor risk factors miscellaneous minor risk factors include occult malignancy, neurological disability, thrombotic disorders, obesity, inflammatory bowel disease, nephrotic syndrome, dialysis, myeloproliferative disorders, and Behcet disease. Now I will speak little about the risk of malignancy and inherited thrombophilias. Risk of malignancy. Occult cancer will be present in 7 to 12% of patients presenting with idiopathic venous thromboembolism. National Institute for Health and Care Excellence Guidance 2012 recommends considering further investigations for cancer with an abdominopelvic computed tomography and a mammogram for a woman in all those aged more than 40 with the first episodes of unprovoked PE or DVT. No studies so far show that this strategy leads to a reduction in cancer related mortality. Now, inherited thrombophilias. 25 to 50% of patients with venous thromboembolism have an identifiable inherited thrombophilia, as for example, antiphospholipid syndrome, deficiency of antithrombin 3, a prothrombin gene defect, protein C or protein S deficiency. This usually need to interact with an additional acquired risk factors to cause venous thromboembolism. Factor 5 Leiden is present in 5% of population and 20% of patients presenting with thrombosis. If antiphospholipid syndrome is suspected at the time of pulmonary embolism diagnosis, such as young patients who has no other obvious risk factors, this has implications for the anticoagulation choice. Direct oral anticoagulant DOAC are not recommended because of the increased risk of thrombosis. Current recommendations do not advocate routine screening for inheritable thrombophilias unless in specific circumstances, and the number needed to test to prevent an episode of venous thromboembolism would be very high. In addition, detecting a heritable thrombophilia does not predict a significantly higher rate or earlier occurrence of venous thromboembolism in the absence of secondary risk factor. We consider thrombophilia testing in patients with recurrent venous thrombosis, patients below 40 with venous thrombosis with no obvious risk factors, patients aged below 40 with venous thrombosis with no obvious risk factors, thrombosis secondary to pregnancy, such as oral contraceptive pills and hormone replacement therapy, thrombosis at unusual sites, such as cerebral, mesenteric, portal, or hepatic veins, don't offer testing in those continuing lifelong anticoagulation or in those with provoked clot. All, ex- all except factors, all except factor 5 Leiden deficiency and thrombin gene mutation need to be tested for when the patient is off anticoagulants. The economy class syndrome refers to thromboembolic disease associated with long distance sedentary travel, refers to thromboembolic disease associated with long distance sedentary travel with an increasing incidence of disease with increasing distance traveled. A 2001 study of more than 135 million passengers showed an incidence of pulmonary embolism of 1.5 cases per million for travel over 5,000 kilometers, correlated with 0.01 cases per million for travel under 5,000 kilometers. For travel over 10,000 kilometers, the incidence increased to 4.8 cases per million. Clinical features of thromboembolism in the next video.